This meeting is being recorded.
Right. Good afternoon, everybody. Thank you for joining us this late in the day. My name is Nicole Cleaver. I work in the marketing department here at Rothman Orthopedics, and I will be the host for this afternoon's event. Today, we're talking about the top 10 most common questions about hip and knee replacement with Dr. Alvin. So what I did was I prepared a presentation so you can read along with the questions. I'm going to ask him the question, and then he's going to answer it. One thing to note, there is also a chat option. So if you hover your mouse toward the bottom of your screen, it'll say chat, and it'll bring up a chat box. As we're going through, if there's any questions that you have, feel free to enter them in that box. They'll come to me, and then I'll ask them as appropriate. And then we also have a couple minutes at the end for Q&A as well. So feel free to type those questions in and save anything you have for the end. I think you'll find this very informative. We have a lot of great questions. So let's get started. So this is Dr. Alvin. He's a hip and knee replacement surgeon here with us at Rothman Orthopedics. Dr. Alvin, why don't you tell us a little bit about your background?
Hi, everyone. My name is Alvin Ong. I am an associate professor of orthopedic surgery at Jefferson University Hospital. I work out of our Egg Harbor Township office in South Jersey. I specialize in hip and knee replacement. We do quite a bit of surgery every year. I've been in practice for 20 years, and I think I'm able to answer these very difficult top 10 questions that Nicole Cleaver has set aside for us. But what I like to do is I'd like to keep this light and entertaining, hopefully, and of course, informative. And if you guys have any question pertaining to the particular topic we're talking about at that time, please feel free to go ahead and use the chat box to ask us pertinent questions about that particular topic. And I'll spend as much time or as little time as possible to discuss the topic. So if any questions come up pertaining to that topic, we can certainly stop and discuss them.
Awesome. So let's dive right in. First things first, how do I know I need a hip or a knee replacement?
So this is a good first question to discuss because oftentimes when a patient comes in and they have pain, they're very surprised if I explain to them that they may or may not need an artificial joint. And so there's several criteria that determine whether or not you need a hip or knee replacement. Just as you know, this is an elective procedure. And so at the end of the day, it's really patient's choice. I can sort of give you the information. I can do the diagnostics. I can explain to you what can be done. But basically, the need for hip and knee replacement takes many factors. So the patient has to have discomfort. We have to have some type of imaging that show that the joint that is involved is worn out. And certainly what we like to also see is that the patient has tried conserved treatment modalities that have failed. So let's sort of dive into this. So basically, symptoms. So the first thing is that you got to feel pain. And with the hip, it's typically groin pain, thigh pain, deep buttock pain, and knee pain. So I always explain to the patient that this was Family Feud and we wanted to look at the top 4 answers on the board on do I need a hip replacement. The top 4 answers of the symptoms of needing a hip replacement is number 1, groin pain, number 2, deep buttock pain, number 3 is thigh pain, and number 4 is knee pain. In fact, some patients come in just with knee pain and they scratch their head and they're so surprised that I told them that I wanted a hip x-ray and I wanted to examine their hip. And oftentimes a hip problem will manifest as pain in the distal thigh and knee. And so that's first thing, symptoms. What about the knee? Well, typically in the knee, most of us, 90% of us are going to end up with arthritis on the inside half of our knee, or we end up bow-legged. And so a lot of times when we talk about symptoms, the symptoms of a knee is arthritic knee is a pain in the inside half of the knee. 10% of us will end up with a knock-kneed knee where the arthritis is on the outside half of the knee. And so we can have pain on the outside half of the knee. Also, we can have pain in the back of the knee. And one of the predominant symptoms of both hip and knee problems is stiffness, meaning limited range of motion. So in the hip, for instance, I always say, you know, you lose the rotation. So first thing is losing rotation. And then oftentimes a patient will lose extension, which means they have a hard time laying flat in bed. With the knee, oftentimes they can't bend their knee too far back, or they have limited ability to extend their knee, to flatten their knee out when they're in bed. And so those are the most common. And then of course, the last thing is swelling. So oftentimes it's hard to find a hip that's swollen, but certain patients will tell you, you know, this hip feels bigger or more full than the other hip. But in the knee, it's very, very easy because the soft tissues around the knee are very thin. And therefore, in most patients, if your knee swells, you can easily tell the loss of contour, the loss of shape. And of course, the knee looks a lot bigger than the opposite leg if the other leg is normal. Now, just because you have pain, just because you have stiffness, just because you have swelling doesn't mean you need a knee replacement or a hip replacement. So we talk about conserved treatment modalities. And so a lot of times, and that's falling into the next questions, but so I won't mention too much, but what I'll say is that patients who fail conserved treatments, and we'll go ahead and talk about that in the next question, and they've exhausted their conserved treatment modalities, that's when we discuss hip and knee replacement. I will tell you though, I have less tolerance for delay of surgery in my older patients. So I always say that there's no good time to have surgery, but there's an optimal time to have surgery. So a patient who has symptoms, they have x-ray findings, they have tried some conservative modalities, which we'll go over in a second, and they are much older, they have medical issues. I always tell them, you know, consider the risks. And so I always tell patients the optimal age to have surgery is between 65 and 75. Now, that doesn't mean that you can't be younger or older. It's just more optimal to have it around that stage. I think that age is between really 60 and 75. And the reason being is that you don't want to be too young when you first get started in joint replacement, but you also certainly don't want to wait until the end of your life to have surgery. And because obviously surgery becomes more dangerous as you get older. I always say you don't get healthier as you get older. Typically, we get less healthy and more frail. And so if you're looking at a major operation, just such as a hip and knee replacement, I think it's best to do it when you're still healthy.
To that point, a question came in from Loretta. She said, what can you say about no knee pain when sleeping or sitting, but immediately on standing or walking, the pain and instability occurs?
So that's perfect scenario for an arthritic knee. In fact, that's what we expect. So when you have arthritis, you basically lost the cartilage, the natural covering of your bones. So, you know, we always watch, you know, baseball and football athletes. They run very quickly, they jump, they tackle, and they get right back up and do it again when they fall. And you wonder how these athletes can get around so easily without getting hurt. And yet, as we get older and we look at our own body, you know, we have pain, we have difficulty standing, we can't get up when we fall, and we wonder how are they able to do it and we can't. And because a young athlete has normal cartilage, they have normal covering around their joints. And believe it or not, cartilage is, number one, very cushiony, number two, has no nerves, and extremely smooth. And so you have very good mobility, no pain, and it's shock absorbing. Now, guess what? Your bones are full of nerves. So you can imagine that when you're getting close to bone on bone, when you're losing your cartilage, you've now exposed all the nerves in your knees or hips. And so when you stand up and put your body weight on it, you're basically taking exposed nerves on one end of your bone and basically putting pressure on exposed nerves on the other end of your bone. And therefore you have pain. And of course the bones are no longer smooth, because remember, it's the cartilage that's smooth. And so if you lose the cartilage, you become less, there's more friction, and therefore the knees don't quite fit quite right with each other, and the joints don't quite fit. And so there's more chances of stiffness and instability. So to get back to that question that Loretta asked, why does it not hurt when I'm lying down? It's because you're basically taking that bone and basically spreading the bones apart so the nerves don't touch each other. As soon as you get up on your feet, you're basically taking your thigh bone and you're pushing against your shin bone, and all the nerve, because there's no cartilage left, all the nerves are now touching each other and causing pain. I hope that answered that question.
No, I think that was great. So what non-surgical options exist before a total knee or a total hip replacement?
So the first and foremost, I think, is basically the least amount of intervention, the better. So for instance, I will tell you that the number one thing we recommend is modifying your activities. So patient says, you know, when I play tennis, or when I do cutting sports, or when I jog, or when I climb steps, my knees hurt or my hips hurt. And we often say, well, if you can avoid those activities, that would be better for you. Secondly, weight loss. Obviously, if you lose some weight, and you don't have to be, I'm not even talking about people who are very, very big people. I'm just talking about normal people. If you take a few pounds off, it actually helps your joints. It actually makes it less amount of work for the pressure against your joints, and therefore pain often improves. With regard to other interventions like anti-inflammatory medication like Advil, Naproxen, Aleve, those things are very good first-line agent for treatment. And I think they do a very good job of taking care of the pain. There's also other things like steroid injections. And I think that it has become quite popular to give a cortisone shot in the knee or the hip before the surgery. And in fact, I personally recommend at least 1 or 2 injections to see whether or not that will alleviate some of your discomfort. For the knee itself, there's other type of injections called viscosupplementation. Essentially what they do is they basically, this used to be popularized and called chicken shots. And obviously these medications are now synthetic. They're not really made out of the chicken parts anymore. But essentially what they do is they take artificial material that basically mimics the fluid that your knee joint makes, and we're starting to give you fluid replacement therapy. And this is FDA approved for the knee. I will tell you, it does not change the natural history of the disease. It doesn't make the arthritis go away, but certainly it lubricates the knee. It has some anti-inflammatory qualities, so it will decrease the pain. And certainly a lot of patients feel that their knee pain is improved and they're able to move better. Unfortunately, it does not work for everybody. And the studies have shown that it works better when the arthritis is mild, and it does not work as well if the arthritis is severe. And so you just have to, oftentimes I tell patients, there's nothing wrong with trying. And I think it's worth trying everything under the sun before considering surgery. And so with regard to non-surgical options, I think that those are sort of the things we discussed. So I will summarize again: activity modification, weight loss, anti-inflammatory medication, and injectables. Now, let's talk about braces. So with regard to the knee, you can consider using bracing. And there are specialty braces that they're called unloader braces, and they basically unload the part of the knee that is arthritic. There's also stabilizer braces. So for instance, in patients who feel that their knee is unstable, a brace can give you some stability by supporting the knee structure, and so it feels more stable when you walk. Unfortunately, the problem with bracing is that they work only if you use it. And what I found in my 20-year career is that a lot of patients oftentimes feel that the braces need to be very tight and uncomfortable before they get any benefits from the brace. And therefore, utilization is very short period. In fact, I myself use a brace for my left knee, but I only use it when I play sports, like if I hit the ball with my daughter at tennis, or if I play pickleball with my wife, I will go ahead and use a brace for stability, but I can't tolerate it for 12 hours a day that I'm working. And so I think a lot of people feel the same way with bracing. You know, they slip, they obviously impede motion. And of course, in the middle of summer, they get very hot and sweaty and they cut off the circulation. So I think that bracing in itself has limited use unless the patient is very religious about using it. And then there's cane, walkers, and crutches, and certainly these seems extreme. A lot my 75-year-old patients will tell me they're too young to use a cane or they're too young to use a walker, and certainly in the United States, I think that we all feel very young. Unfortunately, the use of cane and walker, although very unpopular, can be very, very helpful. And so I will tell you that especially if patients have instability or they feel weak and they feel like they can fall, I think using a walking aid such as a cane or a walker may be very useful in treatment of non-surgical treatment of arthritis before considering replacement. Do you have any, Nicole, is there any related questions to this?
None that have come through regarding this. We do have one for our next slide, so let's move to that one. Next question is, how long does a replacement last? You talked about the ideal age. However, to that point, we did have one question come through from Diane. She said, what if you are bone on bone, but are at a young age of 45 and visco injections have not worked?
So that's a very good question. And the good news is that, and again, I'm very fortunate to have, been working as an orthopedic surgeon in what we call the golden age of joint replacement. The last 20 years, so many things have technologically been advanced that has made joint replacement work better, feel more normal, and of course, last longer. And so we'll break it up to hips and knees. So let's start with the knee because, this particular example of how old is she? 45? Mm-hmm. So, you're not alone. Okay, Diane. There's a lot of patients out there that I see, even in their 30s, that come in and they've had ACL reconstruction. They injured their knee skiing or playing tennis, soccer. They've had multiple surgeries arthroscopically. They've had injections. They're wearing a brace. And at the end of the day, they're bone on bone and they're technically young for the replacement. Like when I said to you, optimally, you want to be like 60 and above before you consider knee replacement. What do we do with those patients? Well, I think that basically the long and short of it is that we have to have a very serious individual discussion about your condition. First of all, as far as the knee is concerned, there's so many technology that has occurred over the last 20 years, such as kinematically correct knee. Kinematically correct knee means that the knee tries to mimic natural knee motion. Second, there is robotics. So now the robotic age, we are now putting in knees with the aid of a robot. Now people believe that the robot does the surgery and I just sit there, but that's not true. I actually do the surgery and we just use the robot to control what we dictate or what we want to do for the knee replacement. And typically what we do is we get some imaging studies. We can size fit the knee better so that the results are much better and we can balance the knee better. And then of course, there's improvement in the material. So there is something called the polyethylene, which is the cushion, if you will, or the plastic that goes between the sandwich that goes between the knee replacement And we found that cross-linking polyethylene, which is a chemical bonding of the plastic, and we changed that actually the knees last longer. So in the beginning of my practice in 2000, I would tell patients that the knees would last like 10 years. Now I'm telling patients that they will last 20 years. And I think there's a lot of literature that has shown that put in well and with good material, that the knees tend to last a lot longer. So we say 20 years. Now, what else is there for very young patients? Well, we now start talking about cementless implants. So traditionally, knees are put in with the use of glue. Now we're putting knees in without glue. And certain individuals are candidates for this if they have good bone quality, their ligaments are intact, they're not too crooked, they're not allergic to certain metallic parts. They can be candidates for cementless implants. Cementless implants is where the bone knits directly into the metallic parts. And this makes the implants more durable, longer lasting, and certainly allows patients to return to more aggressive activities that traditionally we recommend against. How about the hip? Well, the hip, I would say, is a technology. Hip replacement in general is a technology that's 10 to 15 years older than knee replacement, and therefore there's a lot more technological advancement in hip replacement. The other thing is hip replacement is a ball and socket joint as opposed to a knee, where the knee actually has rotation, sliding, and a lot more movement that's very, very mechanically different from a hip. So in hip technology, we already use cementless, we already use ceramics, and a lot of times we don't have what they call an age requirement for hips. Hips tend to last a very long time. In fact, before Dr. Rothman passed away, he would tell us that he believed that the modern hip replacement should last a lifetime. And when we say a lifetime, over 30 years. And I'll tell you, in the 20 years I've been in practice, we have not seen any of the modern hips we put in wear out. So I think that's a very, very strong statement. And there's enough proof now that we believe that hip replacement can be a lifetime procedure. Now, everything wears out, of course. And so what happens when they wear out? Well, if only the plastic wears out, all we do is change the plastic. So for the young, really, really young patients, the knee patients or the hip patients out in the audience, just so you understand that just because the knee is 15 years old, the implant that just doesn't fall apart and basically have to be removed. A lot of times we can do what we call tune-ups. And, basically we go in there and change the plastic out. We change what's worn out. And we don't have to change necessarily everything in the knee. And again, that's an individualized thing. That's what we discuss on an individual basis. It really depends on what is worn out at the time of the surgery. And so I can't say that every patient at 15 years only gets a minor procedure, but I will tell you in my practice, the majority of patients have done well. And at the 15-year mark for knees, we've been very successful in just changing out the plastic, which is a very minor procedure. It's a 30-minute procedure in most patients. And the hope is that they will get another 15 to 20 years out of it. Now, how about being too old? Okay. So I will tell you that there's really no age that's too old. And if you ask me, the oldest knee replacement that I've ever done in my career is a patient who's 96. The oldest hip replacement I've done, and I'm not talking about a patient who broke something. I'm not talking about a hip fracture patient who ends up in emergency room. I'm talking about a patient who walked into my office with hip arthritis, and we had a long discussion about hip replacement and wanted hip replacement electively. That was a 91-year-old patient. And so really age is just a number. It's really everything else. Mentation, how the patient's doing mentally, health, medical health. So how are their heart functioning? How are their lung functioning? How are they nutritionally? how are their mobility, and what are their life expectancies. So if a patient's extremely healthy, um, uh, good mind, independent, and has significant arthritis that's going to hold them back, we can certainly offer them joint replacement.
While we're on this topic, before we go to the next slide, Loretta had another great question.
Yes.
She said, in what year did the new hips begin being used? The new hips that you referred to.
So there are a lot of quote unquote new hips. So the highly cross-linked polyethylene, what we call the improvement in the plastic that has actually revolutionized hip replacement, was in the late 90s. And then the ceramic on ceramic was in the early 2000s. So when I say new hips, these are the technologies that what are called game-changing technologies are reaching 20 years old. And I will tell you, in the last 20 years when we were using these, we haven't seen them wear out. Now, there's a lot of new technologies that are introduced almost every other year in hip and knees, but they're not groundbreaking. They may change the design a little bit. They may change the locking mechanism. They may change the size of the ball. They may have more small sizes, bigger sizes. They may have better instrumentation putting in. So hip replacements and knee replacements are being improved constantly. These companies are coming out just like new cars. Every year there's something new. But when we're talking about game-changing technology, like when's the first electric car that came out? When is the first four-wheel drive that came out? When was the first pickup truck that came out? When was the first halogen light that came out? When was the GPS first came out? When we're talking about in the world of hip and knees, when we're talking about game-changing technologies, often most of them are occurring in the last decade or two, as far as improvement in what you call longevity. Any other questions in that topic?
No, nothing there. Moving on. What is quad sparing knees? And let's talk about minimally invasive surgery.
Okay, so let's talk about quad sparing knees, and that pertains specifically to obviously knee replacement. And then minimally invasive surgery will go ahead and discuss hip replacement. So quad sparing is actually a layman's term. It basically is a set of procedures that spares the quadriceps tendon. So if you look at your quadriceps muscle, so in fact, if you guys Google Arnold Schwarzenegger flexing his thigh muscles, you can see all those four muscles bulge out in Arnold Schwarzenegger's thighs. And the idea is that there's a tendon that attaches all those muscles to your kneecap. And the idea is that if you go ahead and cut through that quadricep tendon, it basically shuts down all those muscles for a period of time. Basically, those muscles go to sleep. And so quad sparing surgery is short for quadricep tendon sparing procedure, which means that if you spare the quadricep tendon, and there's several ways to talk about this. You either split the one muscle on the inner aspect of your thigh called the vastus medialis, and you go between fibers, not cut through fibers, or you go underneath that muscle. You basically will spare the quadriceps muscle from going to sleep. And so the advantages of a quad sparing procedure is that most patients can get up and walk the same day. And now you have to rewind through history. And, we've been doing quad sparing now for a decade. And I will tell you, when we didn't do quad sparing, the patients would need a walker because they feel like their legs was, wet noodle. It felt like when they stood up, the leg would want to buckle out from under them. With the new technique with quad sparing, patients are able to bear weight. Now, it doesn't mean they're 100% strong, but they're probably, 75% strong, and 75% is all you need to walk around. And so quad sparing was a game changer procedure. It didn't change the longevity of the knee replacement, but it definitely changed the rehabilitation of a knee replacement. The patients were able to go home sooner. They were able to move around better, and a lot of patients states that the range of motion came back sooner, and they had less pain. Now, what about minimally invasive hips? Well, minimally invasive hips is what they call direct anterior approach. Direct anterior approach is where you basically move the incision from the front of the hip, the side of the hip to the front of the hip, and essentially, it basically allowed us not to cut into the muscle. And remember, this is basically the same theme when we talk about knee replacement. The less soft tissue you damage, the better the patient does. And so with a direct anterior approach, you're able to go between muscles. And when you go between muscles, the patient loses less blood because you're not cutting into the muscles, which then bleeds. You have less pain. And the patient's able to get up and walk the same day. In fact, we do a lot of same-day surgeries now, both hips and knees. And I will tell you, the patients can basically walk several hours after their joint replacement, and they often can go home the same day if they're healthy enough. And so what surgical approach do I recommend? So again, very individualized, and I like to see the patients in my office to look at their x-rays, examine them before I recommend anything. But I will say 99% of the surgeries I do are direct anterior approach, which means I do a minimally invasive procedure in the front of the thigh, and it's between muscles, not cutting muscles, and it's I believe is the workhorse of my surgical technique. Now, when does this does not apply to the patient? Well, there's several patients who are not candidate for this, and that falls into that 1% of those patients. And it's typically patients with a lot of hardware. So this is not a virgin hip. This patient has had a break, they've had a car accident, they have rods and screws in there, or patients with significant deformity, patients where their legs are very short, or they've waited too long and they're extremely deformed, and makes the surgical dissection very, very difficult. And in those cases, we like to use a traditional approach, which we call a lateral approach, where unfortunately we have to cut some muscles in order to do it. Now, remember, we all end up in the same place. So by 6 weeks, patients all catch up. But it's that first 6 weeks we're talking about when we talk about minimally invasive knees or minimally invasive hips. I think the advantage of minimally invasive surgery has to be beneficial to the patient, especially to the carpentry that we're doing. So if it's a very, very difficult carpentry, very difficult surgery because we're chasing after rods and screws, or there's a significant deformity in the joint, oftentimes we will tell the patient, listen, it's not worth it to you. It's highly dangerous, etc. And we will often recommend a different approach. But I will tell you, 99% of my patients get a minimally invasive hip replacement approach.
Unique question came through regarding hip replacements from Anthony. He wants to know if it's true that you'd have to dislocate the hip joint to perform the surgery.
Yes. You always have to dislocate the hip joint to perform the surgery. And let me clarify this because it sounds really scary, okay? So God put the natural ball in your socket. And in order for me to get to that ball and replace the ball, we have to sublux and separate the ball from the socket. And this allows me to do the surgery. And so by definition, in order to do a hip replacement, you have to dislocate the hip. It doesn't mean that we do it very aggressively. It doesn't mean that it's very traumatic. In fact, what we do is an atraumatic hip dislocation, which means that we actually do in situ. In situ means we leave the hip in place. We make the bone cuts with special instrumentation, and then we remove the ball from the joint, and then we do the hip replacement. So it's actually very atraumatic to do that.
All right, let's move to our next question. You did mention robot-assisted surgery. So can you quickly talk through some of the pros and cons of robotic-assisted joint replacement surgery?
Absolutely. So I just wanted to clarify that I do a lot of robotic surgery. And that doesn't mean it's the right thing for every patient. And so I will tell you some of the cons first, because I think that a guy like me who does a lot of robot, I'm in danger of trying to sell the robot to every patient, which is not my intention. My intention is to do my best job that I can for a particular patient, and I want to make sure that that patient will benefit from that technology. So let's talk about the cons. So what's the cons of robot-assisted joint replacement right now is that we have to put pins in your shin bone and in your thigh bone. And in the hip, we have to put pins in your pelvis in order, additional pins that we normally don't use, into your knee and hip area, because the robot in general is a blind machine. And what they do is they cannot detect flesh and bone. And so what you want to do is you want to have, a robot has this, what they call a camera, that can detect metallic parts or LED lights. And so what we need to do is we need to attach an LED receiver onto your body at the time of the surgery, so that when we move your leg in place, the robot can pick up the motion of the knee and can detect whether the knee is crooked or unstable at the time of the surgery. Now, obviously, this is a necessary evil, because anytime you put pins into the shin bone or in the femur bone, it adds another area of wounds, right? Typically, these are very small. They're not unsightly. They heal nicely. The problem, though, is that if you're a very old patient or you have very osteoporotic bone, I don't feel comfortable putting those pins in your legs, because I feel like maybe your bone can break, or you can have complications with regard to the pins. In fact, there are some case reports of bones breaking with those pins, and therefore we don't like to use them in very, very old people. Another con of robotics is that it takes a longer period of time. And you may say to me, doctor, I want you to take as long as you can, as long as you want, because guess what? I'm in no rush, and this is my leg for the rest of my life. And I totally believe that. When I do joint replacement, I want it to last the patient's entire life. And so I try to do a very good job. That goes without saying. However, there's also the concern that the wound may be open for a longer period of time. And of course, that increases the risk of, number one, infection, and number two, blood clots. And so when we talk about robotic assisted surgery, I typically like to do it when I do a single joint, and I often hesitate when I'm talking about a double knee replacement surgery. So if I'm going to consider doing both your knees at the same time, I often will omit the use of robotics, because I feel like you'll be on the table for too long a period of time, and that may increase your risk of complications. Now let's talk about the pros. Okay, so I sort of told you all the bad things that about robotic assisted surgery. The other bad thing, which at this point in time doesn't matter, is it increases cost. But again, that doesn't affect you or me. What about the pros? Well, from the pro standpoint, I think it's a more accurate procedure. So we can more accurately align the prosthesis, we can size the implants better, we can position the implants better, and we can, more importantly, balance the joint better. And I think that the knee is fairly prime time. Prime time meaning that the robotics for the knee is extremely slick, technologically advanced, and there's now thousands and thousands of knees performed robotically that I think the robotic technology is very, very accurate and very consistent. Not so much so for the hips yet. I think the hips are coming along. I think that the hips software is getting better and better. And I think that in the next 6 months to a year, I think robotic hips may become a really good option for certain patients. I hope that answered the questions. By the way, each company makes their own robot, and so robot has to be used at this time in the United States in 2021 is manufacturer specific. So for instance, if you get a Stryker knee, you use a Stryker robot. If you use a Smith & Nephew knee, you use a Smith & Nephew robot. A Zimmer knee uses a Zimmer robot. They're not interchangeable. So robots is very specific to the implant. And that's good because what happens is that robot is very smart and it has all the specifics of that particular implant, and it makes for a more accurate surgery. Any other questions on that topic?
No, that was great. We did have a couple questions surrounding this next question.
Okay.
It says, can I have both hips or both knees done at the same time?
The answer is yes, but I want to put an asterisk to that, okay? And so double hip replacement is commonly done. Double knee replacements are commonly done. In fact, we do it all the time. But we don't offer it to every patient. And so let's talk about who's a good candidate for double knee replacement. And I just want to talk about the pros. The pros are, there's a lot of pros. So the pros are 1 anesthesia, 1 hospitalization, 1 rehabilitation, 1 time in pain, 1 time in physical therapy, 1 time out of work, 1 time out of life. So those are the pros. What are the cons? No matter how you look at it, it's still 2 major surgeries wrapped up into 1. And so twice the blood loss, twice the cardiac risks, twice the risk of blood clots, because now you have risk of getting blood clots in both legs. You're more sedentary after the surgery. There's a high risk of blood transfusion. It's harder on your heart and lungs. And therefore, I think that in order to be fair to the patient, we offer double hip and knee replacement to super healthy, younger adults. So what does that mean? So for my double knee and double hip replacement candidates, I like to stay younger than 70 years old. I don't want them to have any cardiac disease, so no stents, no history of heart attacks, no angina. They shouldn't be big time smokers. They have to have good lungs. So if you have COPD, if you have any type of lung issues, difficulty breathing, that's not a good candidate. No histories of blood clots, no histories of blood thinners. So if you're on Xarelto or you're on Eliquis or you're on Coumadin long term, or you've had a history of blood clots in the past, you're not a candidate for a double knee replacement. If you have sleep apnea, so that means when you go to sleep, you stop breathing, that's probably not a good candidate for a double knee replacement or double hip replacement. If you have very bad deformity, or you have very, very bad bone, so your bone quality is not good, and you let yourself go to the point where you have so much arthritis that you have very limited range of motion, it's often much better to do them one at a time because you can concentrate on rehabilitating that hip or that knee one at a time. So you give it 100% attention versus only 50% attention. And I think patients do better with single joints when it's that bad. But with that said, if you're under 70, you're super healthy, you're not super heavy, you don't have history of heart and lung disease, I think we can certainly discuss double hip or double knee replacement with you. I saw some questions come up regarding tourniquets.
Yes.
Okay, so tourniquets or no tourniquet? That is the question. And the answer is we do them both. And what are the pros and cons? So there are, unfortunately, a lot of literature that is unfounded. There's no proof that using a tourniquet or not using a tourniquet is better. What we found, though, is that we can do either or. So if the patient is extremely, desirous of not using a tourniquet, we don't have to use a tourniquet. The biggest issue with not using a tourniquet is you lose way more blood at the time of the surgery because there's nothing stopping the blood flow. What are the advantages of not using a tourniquet? Well, patients have less thigh pain, for instance. So people say, well, because I don't have that tourniquet around my thigh, I have less pain. And so there are some literature to suggest that patients who don't use a tourniquet have less thigh pain. That they also bend better. However, we also found that patients oftentimes without a tourniquet may need drains after the surgery because they bleed more at the time of the surgery. And so again, that's a controversial topic. I don't think there's a significant positive or negative to either or. And so as a surgeon, and let me just put it out there. I've done like 8,000 knee replacements. So it's easy for me to do a surgery with or without a tourniquet. I don't think there's much difference. And so I'm very much, in tune with what the patient wants. So we try to please the patient because I don't believe it's dangerous not to use it or to use it. Does that answer your question? I hope that answers your question.
Yeah, I think so.
What other questions pertaining to what we've discussed thus far? Double knee replacement, double hip replacement.
Terry had also submitted another one here that said, can you walk a flight of stairs after bilateral knees?
Not right away. Yes, but the answer is eventually you should be able to walk upstairs. And, we have amazing patients. And, I've been very fortunate enough to have been involved with so many patients' lives. When I look at the number of joint replacement I've done, I told you I've been involved to close to 8,000 knee replacement and probably 4,000 hip replacements. And I will tell you, I have these amazing patients, and I have patients who jog. I have patients who play tennis. I have patients who surf. I have patients who ski, snowboard, water ski. I have these, power jog. They do karate. I've done knee replacement on black belts in martial arts. And so, I think when the patient has the will and they don't have the pain, I think they can do it. Now, that doesn't mean they should be doing that, huh? That's not what I meant. I'm just saying that over the course of the last 20 years of my practice, I've seen patients do amazing things with joint replacement. Any other questions regarding those topics?
No, I think our next question will answer some popular questions as well. What limitations exist after surgery? Can I kneel, garden, do yoga?
Okay, so that's a good one. So as far as the hip is concerned, remember I told you that 99% of the hips I do minimally invasive through the front, called the direct anterior approach. Well, when you look at the literature on direct anterior approach, the risk of dislocation, which means the hip slipping out of place, is like less than 1%, which means it can happen, but it's exceedingly rare. And so with the hip, we tell patients that basically they can do about anything they want. Now, we got to be smart about it, right? Because especially in the first 8 to 12 weeks, we tell patients, the hip is scarring into place, the bone's still knitting into the bone. The bone's still knitting into the implant. And so everything is still healing. And so we tell patients not to do anything too aggressive, like doing splits or anything crazy like that, or running the first 3 months. However, as the hip gets mature, like at the 6 to 9 month stage, I will tell you that a lot of patients do a lot of things, even yoga, and they do many types of sports. And so limitations are very limited, very small limitations for hip replacement patients. Let's talk about the knee though. Now the knee, unfortunately, does not follow the same track as the hip. I will tell you that a lot of my patients don't like to kneel after knee replacement. And a lot of patients say, well, doctor, you told me not to kneel. That's why I don't kneel. It's not because I can't or don't want to kneel. You told me not to kneel. And I will tell you there are several reasons why I tell patients right off the bat that they shouldn't kneel. First, it hurts. So, and this again, this is what patients tell me. kneeling on a metal knee does not feel good. And so I tell patients, you know, you probably shouldn't kneel because it's going to hurt. That's number one. Number two, kneeling on a hard surface directly on your kneecap on a metal knee is not good for your kneecap. So the fear that you're going to either loosen up the patella, prosthesis, or you're going to break the patella, that's a real concern. And so I always tell my patients, you know, I want this to last the rest of your life. I don't want you to put excessive force across the knee. And so I tell patients that the second thing that can occur with kneeling is they could potentially break or dislodge the implant. And does this happen often? No, but it can happen. And I just want you guys to understand that it can happen. So one of the limitations of, I believe the biggest limitations of knee replacement is the kneeling part. And I will tell you that I've operated enough on a lot of, you know, I've been very fortunate. This is a very ethnically diverse community, and we've actually see a lot of, operate on a lot of Southeast Asians, like Indians, and they can sit, you know, cross-legged on the ground, and they often get down on their hands and knees. And I have a lot of younger women who does a lot of yoga and Pilates. And so I know these patients can do it. It's just that you have to take accommodations to protect that kneecap, because it can certainly, number one, cause pain. And of course, I don't want anything to happen to the actual prosthesis. Now let's talk about gardening. I have plenty of patients who garden. But it takes a change in sort of habit. So a lot of patients like to kneel on like a pad on their knees and you know, dig or plant their it's springtime, so you know, people like to plant their little plants and weed, etc. And I tell my patient that that's probably not a good idea. My recommendation is really to use one of those rolling seats and basically use that to garden. I think that's a more sort of viable way to continue your hobby and take care of your garden without, you know, causing pain or injuring your knees. As far as yoga is concerned, there's a few maneuvers that requires you to kneel directly on that knee, and I just tell, there's enough yoga instructors out there to take care of knee replacement patients that they've made accommodation. They'll change the pose, if you will, for yoga in order to accommodate that knee replacement patient. And I have a lot of patients who participate in yoga, and I think that's really, really great activity, and I totally recommend that. Any other questions?
No, not regarding this topic. We'll get to the next one. What's the average length of time until I have full range of motion? With a couple additional questions as well. Very popular. When will my knee feel normal? And then when will I be able to get back to golfing, biking, walking long distances? Lots of questions about climbing the stairs, even as a single knee replacement. And then lastly, most importantly, when will I be able to drive?
Okay, so let's talk about that. So let's break this down. So the first question is, what is the average length of time until I have full range of motion? So believe it or not, range of motion improves up to 1 year after surgery. And that's hard to believe, because you would suspect that most of the healing is done by 8 to 12 weeks. Now, with that said, we want you to get the majority of your motion within the first 6 to 8 weeks. And so some of the things that is hard stops for knee replacement surgeons, we want you to, so there's, if you look at the textbook and you ask experts in the field of what minimum range of motion do you need for daily activities. And when I say daily activities, it's like getting up from a seated position, getting off the toilet, putting your shoes and socks on, going upstairs, climbing downstairs, things of that nature, getting in and out of a car, getting in, out of a bathtub, etc. All the normal things that we all do. Most textbooks will tell you 90 degrees, 90. And I will tell you that's not enough, okay? I don't like 90 degrees. I'm happy for you if you get 90, but I'm not happy for you, okay? I want 120 degrees, okay? And now, just because I want it doesn't mean it happens, right? And I always tell my patients, it's 50% me, 50% you. My job is a surgery. Your job is to get the range of motion back. And I will tell you, and you're asleep during the surgery, so you're not technically there looking and watching me, but I will make your knee, your ankle touch your butt at the time of the surgery. That's my job, okay? And so that knee is going to move completely back. If not, I don't leave the operating room, I adjust it, okay? So I have the ability to adjust the implants around. I can make small adjustments to the implant, to the sizing, to the insert. And so I will tell you, and this is something that you just have to believe, that I do not leave the operating room until you have full range of motion. Now, your job is to get that range of motion back after we leave the operating room. And you have to deal with the swelling, post-surgical pain, and of course, the scar tissue. And some people scar better than others. Some people have more pain and difficulty than others, and some people do better at therapy than others. And everybody's an individual, everybody heals differently. However, we want to see by 4 to 6 weeks that you're over 115 degrees, okay? Because let me tell you, if you're not even close to 115 degrees or 100 degrees by 6 weeks, I'm wanting to take you back to surgery. And the reason being is that we don't want the healing to overseed you, to take over the knee, and next thing you know, you are limited for the rest of your life. And so basically, just to summarize, we like to see 115 degrees by 6 weeks, 5 to 6 weeks. And if those patients reach 115 degrees by 5 to 6 weeks, they will likely be 120 to 125 degrees by 3 to 6 months. And most people tap out at 1 year. Okay? And everybody's limited and individualized on their full range of motion. There's a famous surgeon in the past that says, pre-operative range of motion dictates post-operative range of motion. What does that mean? In layman's term, what you came in with is what you leave with. And essentially, if you let your knee go to the point where it doesn't bend well before you have surgery, the chance of you achieving full range of motion after your surgery is very poor. And that's been time and time again, that's stood the test of time. And that's basically a textbook thing that we learn at a very young age, being a joint replacement surgeon, that pre-operative range of motion dictates post-operative range of motion. So patients with really good motion to begin with often leave with very good range of motion. Patients who have poor motion before their surgery often come, they end up with poor motion after the surgery. Next question. When will my knee feel normal? That's a very good question. So there's actually a study called, or a test called Forgotten Joint Score. And Forgotten Joint Score is actually a measuring device, questionnaire on how patients feel normal, or how normal patients' knees feel. And this could be any joint, shoulders, hips, and knees. I will tell you that the average score for a hip is 100 being you totally forgot, 0 being you are totally aware of your knee. It doesn't feel normal. The hips tend to be high 90s, meaning hip replacements in general feel more normal than knee replacements. Knees, on the other hand, with the current technology of using kinematically correct knee and correct sizing and possibly using robotics to put it in properly, they hit mid-80s. And mid-80s is pretty damn good when it comes to Forgotten Joint Score for knees. They never reach 90s or 100, unfortunately, which gives us a lot of pause, because it tells us that we're getting close, but we're never as good as God made the knee. And so when will you achieve the highest possible score for that individual? So we did a study, and we looked at the patients on Forgotten Joint Score, and we asked them, and we looked at how long it took for the knee to feel the most natural to them. Remember, when I say normal, it's in quotations, because it's never normal. Is 100, a score of 100, and the knees often maxes out at 85. Okay, and most people feel normal in 3 years. So what do I tell patients? It takes a year to recover. It takes 2 to 3 years to forget. I'm going to repeat that. It takes a year to recover from a knee replacement. It takes 2 to 3 years to forget. And remember, you don't completely forget. You forget, you get an 85 point. That's the maximum you can get in a knee. You can totally forget a hip, but you cannot totally forget a knee replacement. Any other questions pertaining to that?
No.
Okay, so the next question is, when will I be able to get back to golfing, biking, walking long distance? Okay, so this is me. Okay, so this is anecdotal. This is me as an individual surgeon. Every surgeon's a little different on what they tell the patients. If you are a golfer and you are an avid golfer and you love to golf and golf is part of your life, I recommend you start hitting golf balls at the range at 4 to 6 weeks. It's part of your rehabilitation. Okay? And so if golfing is part of your life, and I know a lot of those people, my wife, golf is part of her life. She has to play golf all the time. Okay? She thinks about golf. When she's not playing, she's thinking about it. If you're that type of person, you should start hitting golf ball as part of your recovery, as part of your rehabilitation at 4 to 6 weeks. In fact, I want you to start playing 9 holes at the 6 to 8 week mark, and you may not hit driver, but you definitely will hit all your short irons and your putter. And I expect you to play 18 at 3 months. So that's golf. What about things like tennis, racquetball? Racquetball is a dangerous sport. I don't recommend it after knee replacement, but doubles tennis, I totally recommend. And for hip and knee replacement, for tennis or racket sports, I recommend that somebody starts pitching balls to you at the 4 to 6 week mark. So if tennis is very important to you, I would like somebody who is really good at tennis and, maybe a tennis coach or somebody you pay, a friend, and they start pitching balls to you within 1 step. Okay, so you only have to take a step to hit the ball across the net. And basically that's where it starts, because the worst thing that can happen is you trip over your feet after a joint replacement and you break something. And so I tell my patients at the 6 week mark, they start hitting easy balls, and then as they get comfortable with that and they get their mechanics back, they can start to hit further shots. They can start moving up on the court and they can start moving side to side. But I think it has to be a controlled play. It can't be, it can't be for score. What about biking? So biking, we want you to be on a stationary bike as soon as you can be. I don't think there's any limitation with regard to hip or knee when you can start using a bike. In fact, I had one of my friend and a physician that I operated on, he was on a bike at 3 weeks. And, he's a younger gentleman. He had good balance. He's very athletic. So after a hip replacement, he was biking around 3 weeks after the surgery. As far as walking long distances, I want you to start walking about a mile around the 3 month mark, and definitely 2 miles by 6 months. Okay, and that's on one clip. And again, you got to take that with a grain of salt. If you're 80 years old, I don't expect that. But if you're healthy, otherwise healthy, good other knee, good hips, and I did 1 knee or 1 hip on you, and no other medical problem, no spinal stenosis, etc., no COPD, I think that in general, a healthy adult should be able to walk 2 miles with a joint replacement after about 4 to 6 months. Driving. This depends on left and rights, right? So according to New Jersey law, maybe Pennsylvania law as well, that for a right-legged surgery, so right hip or right knee, we let you, it takes 4 weeks for you to be legally able to drive. For a left leg, it's 2 weeks. Now, what's interesting is that a lot of the laws are written around 2 studies that were done in the mid-'80s. In fact, one of the studies was published in Australia, where they don't even drive on the same side of the road. and the other one was done in the United States. And a lot of the studies were done on traditional hip and knee replacement, not minimally invasive. So in fact, I am one of the authors, very happy to present this. In 2015, 2016, we published driving after minimally invasive knee replacement and driving after minimally invasive knee replacement. And what we did was we did what they call a simulation study, where we took a driving module where there is a simulated brake and gas pedal, and we had patients start with their foot on the gas pedal, their right foot, and we had pretend traffic light. And this pretend traffic light would automatically go from green to red without the patients, knowing. And they would have to react to bring their right foot from the gas pedal to the pretend brake pedal, and it would record a time. And this is what they call the reaction time study. And we published this in major journals. And what we find is with minimally invasive hip and knee surgery, that the patient's reaction time returned to normal in about 2 weeks. So in the majority of patients, 85% of patients had the reaction time that was, according to the government, was reasonable to return to driving at 2 weeks after minimally invasive hip and knee replacement. But guess what? The state police doesn't know that. So even though we publish this data, it takes a lot of time for the government to change the rules. And so at this point, we're still recommending 4 weeks for hips and knees if it's right-sided. Is that clear?
Clear.
Okay.
Two more. How about running? Steve asked about running, assuming that you've run prior to surgery.
So running is a very difficult thing for me to recommend. And I will tell you, I have enough patients who run that I know that from a safety standpoint and from the implant breaking standpoint or wearing out standpoint, it's not like immediate that the implant's going to break or wear out. However, I will tell you that these implants are not designed to take that kind of impact. And so what I tell patients, and the earlier questions we answered was how these implants could be what they call lifetime hip or lifetime knee. I think you're shortchanging yourself if you decided to do, if you decided to run on your hip or knee for exercise. Now, if you said to me, I have to save somebody, I gotta run out of a burning building, I gotta run out of, from a rain, I didn't want to get wet, that's okay. Occasional running, I think, is fine, and there's enough of my patients to do that, which I don't believe is detrimental to the joint. However, if you said to me, I'm an avid runner and I like to run 3 to 5 miles, 3 times a week, is that something I can go back to after my hip or knee replacement? I think that's something that I recommend against. And the reason being is that this is an appliance. This is a mechanical device. It has the ability to wear out. It has the ability to fail. And so what we talk about is, on the one hand, we want it to last forever, because in order to get back in there and adjust the parts or redo the parts, we have to cut you open again. We don't want that. As a surgeon, we always say one and done, right? And that's like a favorite saying. It's like, we want to do it once, we want to do it right, and we never, ever want to go back in the same hip or knee again. Now, we'll gladly go to the other knee or the other hip, but we don't want to go back to the same joint if we at all possible. And so if we believe in that, we totally recommend against running, because I think running puts a lot of pressure on the implant and can make it fail sooner, make it wear out sooner.
Lisa had a great question. She's a professional firefighter.
Yes.
How long to full physical abilities after hip replacement, and how long until she can return to work?
So I've had a lot of firefighters, and I treated a lot of correction officers, and I've treated a lot of state policemen, and firefighters in general. They have to carry all that gear, and they have to run. I think the test is like 40 yards or something like that. I don't remember, but I have a lot of firefighters that I've treated in the past. And so I believe that it's individualized, but a lot of patients can return to full duty around 3 to 4 months.
Awesome. We have 2 more slides and then we'll wrap it up.
Okay.
How long will I be in the hospital after surgery? And do I need to go to a rehab facility?
So very good question. And this is ever changing. Now, especially with this current pandemic that we're dealing with, a lot has really changed over the last year. A lot of patients are now going home the same day. And so I think that the majority of patients either go home the same day or stay overnight and go home the next day. And there's several reasons for that. Number one, patients are scared to be with other sick patients or to catch something in the hospital, which is totally understandable. And number two, doctors don't want the patients in the hospital for fear of something going on. Like at present time, now it's March of 2021, everyone that you see in the hospital is going to be vaccinated. So I've been vaccinated since my first vaccination was in mid-December, and I've been vaccinated completely since January. Every one of my staff members, the anesthesiologist, the nurse anesthetist, the circulator, the physician assistant, the scrub nurse, the second assist in the surgery, they're all vaccinated. Most of the nurses in the hospital, in the recovery room, they're all vaccinated. Most of the nurses that take care of you are all vaccinated. So basically, everyone that you see in the hospital are vaccinated. When we have surgery now, everybody's tested before the surgery. So even the patient in the next room has been tested and is tested negative. If they're test positive, they don't come into the hospital, they don't get surgery. So you understand that the safety level of the hospital is so good. However, even with that, we still don't want you in the hospital. And so the majority of our patients are either going home the same day or going home the next day. Now, what does that mean for the rest of the patients? Like the minority of patients who are too old or have, are not medically healthy enough to go home, or they don't have anyone to rely on. There's still rehabilitation facilities out there. And again, all of them require testing and are fairly safe now. However, I will tell you that there's less and less people going to inpatient rehab. And I think that's the take-home message. The take-home message is that a lot has changed over the last several years, and most patients are staying less than 24 hours, and some are going home within 6 hours.
Very cool. Next last question. Will I need to do physical therapy post-operatively?
So that's a great question. And it really depends on what body part we're working on. And so if I'm doing a minimally invasive hip replacement and I'm not cutting muscle, what we call the direct anterior approach. And remember, I tell you that 99% of the patients I do this procedure. Physical therapy is unnecessary. And so most patients either go home the same day or the next day. And we do see a therapist in the hospital, and they give instructions on what not to do, and that's it. And basically the patient's allowed to, walk around and do their normal activities, and there's really minimal restrictions. And typically the hip takes care of itself. As far as knee is concerned, this ranges from the patient. And with a knee replacement, some patients want to do therapy on their own. There's what they call video therapy. Video therapy is where it is done through like an iPad or an iPhone. And basically there's an interactive web management, and they tell you what to do and you do it. There's home therapy where I send a therapist to the house for a couple weeks. There's outpatient therapy. And so it runs the gamut, but overall therapy is necessary after knee replacement, not necessary after hip replacement. And in the knee, you can either do it self-guided, you can do it with a therapist that comes to the house, or you can do it as an outpatient.
And then lastly, what can I do to prepare for a total knee or total hip surgery?
Well, this goes back to the first question. We got to make sure that you definitely need one. And so that requires that you have the right symptoms, the right clinical examination, the right imaging, meaning you have to have feel pain, you got to have the right exam by the doctor, and of course the right x-rays or MRIs that tell you that you have a bad hip or a bad knee. And then you have to at least try to exhaust some of your conserved treatment modalities. So again, to summarize, anti-inflammatory medication, activity modification, weight loss, use of bracing, use of cane, injectables for hip and knee, and of course, activity modification. And if all those fail and you failed your conserved treatment options, and I think, and you have the x-ray findings and of course the clinical and symptoms, I think then that's when you start to think about joint replacement. What do you need to do to prepare? I think that the most important thing is medical health. So a lot of the patients that come in, not all, but a lot of the patients that come in have other medical problems. They have COPD, they have cardiac disease, they have diabetes. And if you possibly can, or if you're planning to have surgery, I think all these things need to be optimized. And the patients who are very successful at this, they go see their cardiologist, they go see their pulmonary doctor, they go see their diabetic doctor and make sure that they're completely optimized. For diabetes, we like to see a hemoglobin A1C of less than 8. For cardiac disease, we want to make sure that your cardiologist have cleared you, especially if you have history of stents or angina or had history of open heart surgery or any type of cardiac problems. If you're on blood thinners, you should make sure that those have been optimized. Obviously, blood thinners are a major potential cause of problems after joint replacement. And of course, if you've gained excessive amount of weight, getting on a very good diet and nutritionally is very important. And that's also opposite true for patients who are malnourished. Older patients who are very, very thin. We look at a pre-albumin level to make sure that they're nutritionally able to heal and recover after major surgery.
You mentioned cortisone shots. How long after a cortisone shot is one eligible for a knee replacement?
So there's a study that was done, a couple of studies actually, that was done probably over 5 years ago now, and pertains to this particular topic. And what they looked at is they looked at close to 40,000 patients, and they stratified the patients that had their joint replacement within a certain amount of time after their injection, and those that were the injections were nowhere close. And what they've shown was there was a small increase in infection in patients who had their injections very close to their surgery. And so at the Rothman Institute, we're always talking about safety first, and of course we always want to limit complications. And so one of the things that we've instituted is that we like to, at minimum, we like to wait close to 3 months before you have surgery if you've had a shot. We believe an injection is a contamination. Somebody stuck a needle in you in that particular area that we're going to operate on, and we'd like your body to clear itself of any problems prior to going in and doing the joint replacement. Of course, there's always exceptions to the rule. There's a recent study from Harvard that shows that possibly 6 weeks is enough wait time. But again, that's just one study against the other 2 studies that were published some time ago. So I think the common sense thing is don't have surgery, close to, close in proximity in temporarily in time to your joint replacement. I think joint replacement is a very sterile field and can last a lifetime, and it's a wonderful procedure with high success rate. I mean, a success rate of joint replacement typically in the high 90s, and I think that ruining it with an infection because of an injection is a silly thing and should be avoided.
Finally, where do you see patients at and where do you operate?
So I see patients here in Egg Harbor Township locally in Atlantic County. For all the people who, want to see me, we're located in Egg Harbor Township. We have a very, very nice facility. We see lots and lots of patients. I see patients on Tuesdays and Thursdays at the office, and we run full days of office. In fact, I was here all day today before I came here to do this talk. We do surgeries at Atlantic Care. You see on the picture there is the Centers of Orthopedic Surgery, which is in the campus in our Egg Harbor Township. This is our surgery center. This is our same-day surgery suite, although they do have availability to keep you 23-hour stay. So I think this is a great option. It's brand new. It's beautiful, very low complication risk, extremely nice staff, and I think you guys will enjoy this. And of course, we also go to Atlantic Care. I operate mainly at the mainland division in Pomona. I've been there since 2000, so this is my 21st year. And I think that, and like I said, we've done over 10,000 surgeries. I've done over 10,000 surgeries there, and I think it's a wonderful place. We have 5-star rating nationally for hip and knees. In fact, I brought my own mother here from New York because of the, it's a wonderful facility, extremely clean, very low infection rates, and we have extremely high success rates. So I think that, if it's good enough for my mother, it's good enough for my patients. So I think that, I highly recommend it.
Awesome. Thank you so much, Dr. Ong. This concludes our program for tonight. Just so that you do know, this entire presentation has been recorded. It will go out by mid next week via YouTube link. So you're welcome to share it with friends, family, and review it yourself. In that email, it'll also contain my contact information. So feel free to email me with any additional questions you may have. But again, thank you for joining us. Thank you, Dr. Ong. I think this has been super informative.
Well, I'll just spend the last 2 minutes answering a couple of questions I just saw in the chat message, if you don't mind. So as far as the COVID vaccine, I think everyone should get their vaccine. And I don't think there's any rule of thumb when you can have surgery after the COVID vaccine. But if you're gonna think about surgery, make sure you get your COVID vaccine. I don't think it's a deterrent to having surgery. Most people say, wait a couple weeks and get your surgery. So I think that if you can get it 2 weeks before the surgery, that's fantastic. We do not do hip resurfacing procedures anymore. There's a lot of bad press about hip resurfacing. Hip resurfacing has basically been discontinued for most centers in the United States for good reason. Hip resurfacing is a metal-on-metal product, and unfortunately, they have high failure rates, and they have caused significant issues with, muscle loss and bone destruction, and patients have gotten very sick with them, and they've really created a major havoc. There are still people around the country, very small centers, that continue to do hip resurfacing, but at the Rothman Institute, you will not get a hip resurfacing because it is something that is, number one, controversial and potentially dangerous for the patient.
And then Rosie had one last question to come through, which I think you touched on. How long after knee replacement until you can go up the stairs?
Oh, yes. I apologize, Rosie. I meant to answer that question. So stair climbing is one of the most difficult things humans do. I encourage people who have stairs to start climbing stairs right away. In fact, patients who have surgery with me and they say, I want to go home, but I have stairs. I say, well, as soon as you feel comfortable, please go up the stairs and use it sparingly, meaning come down the stair one time, in the morning, spend the rest of your day, most of your day downstairs, and then have your wife or husband help you up the stairs at night, because I really want you to go back to normalcy as soon as possible. So for instance, I want you to sleep in the master. I want you to sleep in your own bed, shower in your own, in the master bedroom, and live as normal a life as possible as soon as possible.
All right.
I hope that answers your question. So it's different for everybody, but I think we encourage you to to learn how to climb stairs and descend stairs as soon as possible. A couple more questions here. No, you do not need an MRI before knee replacement. Cortisone shot overall decreases is an anti-inflammatory, and therefore will stop the inflammation. And if you think about it, we were designed, God designed us to have inflammation as a healing process. And I believe that multiple cortisone injection over a long period of time will lead to more arthritis. And we're talking years. So I don't think a few injections to hold off surgery until you're older, or, so that before you retire, or, to wait until a certain part of the year so that it's more convenient, will do enough damage to worry about. So I'm not so worried about the amount of damage cortisone injections will do. I think that I think it's one of the workhorse of treatment before surgery, and I think that everyone should consider doing it because I think it's worthwhile. As far as things like PRP, I see in other questions like that. The PRP, there's absolutely no proof that PRP works. And I think that I think it's worth a try. I don't think it's dangerous, but there's no proof that it will grow cartilage.
And then we'll round it out with the last one, which I believe you also touched on. How about sitting on the floor Indian style?
Oh, I have a lot of Indian patients who sit Indian or cross-legged. I don't like to say Indian style, but cross-legged on the floor. And I think it's very doable after hip and knee replacement. So in fact, I have videos of my patients doing it, getting up from the ground and getting back up and going back down. So I think it's not an unreasonable thing to do.
All right, I'm gonna cut us off here. Just
okay, very good.
Thank you. Over time. So
yeah.
Again, thank you, Dr. Ong. Thank you, everybody. Be on the lookout mid next week for an email from me with the recording and my contact information should you need anything.
So if this is really helpful, I'm more than happy to do this again. This is a lot of fun for me, and I spend a lot of time with patients talking about this very same questions. And certainly we can revisit some of these questions or discuss even different questions next time around. And is there a survey after this?
I can send one.
Yeah, if people want to do something like this again, and if you found this helpful and at the least entertaining, I'm more than happy to go ahead and pitch questions again. I think this is a very, very good forum for discussion. A lot of patients don't feel that they get enough time with the doctor, and they come into the office and they forget to ask the question they really want to ask. So I think this is a good way to do this.
I agree.
All right. Thank you very much, guys. I appreciate your time.